The following lecture examines mycobacteria and discusses the general properties and diseases caused by organisms that belong to the Mycobacterium genus of bacteria. Mycobacterium is a big genus of bacterial organisms that includes more than 190 species. These are non-motile, non-spore-forming organisms that are aerobic. Under the microscope, they look slender, slightly curved, or like straight bacilli. They do not stain very well with your typical gram stain because they have a high lipid content in the cell wall. However, you may see them as weakly gram-positive. So staining requires application of heat and prolonged time of staining. As you'll see later, we will talk about how you may stain these organisms, but due to the method of staining, they are referred to as acid-fast. Once they are stained, they become resistant to acid-alcohol decolorization. And that's because they have a high lipid content in their cell wall. This high lipid content allows resistance to harsh environments, such as disinfectants, as well as desiccation. Moreover, it plays a factor in immune system evasion. 60% of the mycobacterial cell wall consists of lipids. Now you are quite familiar with the gram-negative cell wall and the gram-positive cell wall. The gram-negative one contains peptidoglycan in thin layer form. As for the gram-positive, it's a thick layer of peptidoglycan. Now, the case of mycobacteria, they also contain or harbor peptidoglycan in their cell wall. However, in addition to that, the cell contains a lot of lipids. Now, this includes mycolic acids, which are free lipids, as well as glycolipids and peptidoglycolipids. The glycolipids are antigenic, and they constitute about 25% of the dry cell weight. The primary exterior glycolipid is the court factor, and this court factor plays a role in what the organism looks like under the microscope. So they look like snakes, so they are serpentine. They are elongated bacteria, so they form elongated bacterial cords. And this is also due to the court factor. The court factor is very important for the organism because it helps it out with immune evasion, and hence it is a virulence factor. So going back to staining of these organisms, since we said that we cannot stain them with a gram stain due to the presence of the lipids in the cell wall, we have to stain them with a special procedure. For this to work, what we do is you take your bacterial sample, you place it on a slide, and then you place it over boiling water for 8 minutes. However, in addition to the slide itself, you add on top of the slide a particular stain such as carbylfuchine. So again, to reiterate, what you do is you take your slide, you add your bacterial sample to it, and then you add your carbylfuchine, your stain, or sometimes a different stain may be used, and then you have to apply heat to it. You do not subject it to direct heat. However, what you usually do is put it on top of a beaker with boiling water underneath it. And so the steam from the beaker itself will help the sort of melting of the lipids present in the cell wall that will then allow the entrance of the stain into the cell wall. Afterwards, what you do is you cool the slide, and now the lipids will reform, and then whatever stain has entered the bacteria will kind of be stuck there. So what you do next is you wash with acid alcohol, which should basically remove all of the stain that is present there, except if it is within the bacterial cell. And so everything gets decolorized except the bacteria itself. Next, we rinse the slide and we do some counter staining, usually with methylene blue. And then again, you rinse your slide, and then you can examine it under the microscope and look for the acid-fast organisms. As a non-taxonomic, rather rudimentary classification, mycobacteria are classified somewhat based on the diseases they can cause. The first type are the Mycobacterium tuberculosis complex, or the MTBC. This includes multiple organisms that can cause tuberculosis-like symptoms and disease, as you will see later on in the lecture. This includes the very famous Mycobacterium tuberculosis, the rather poster child of these organisms, as well as Mycobacterium bovis. The second type are the mycobacteria other than tuberculosis, or MOTT, also referred to as non-tuberculous mycobacteria, or NTM. And these are classified based on how fast they grow and how and why they produce pigment. This is called the Runyon classification. The Runyon group 1, these are slow growers. They take about 3 to 8 weeks. They are photochromogens, and so they produce yellow pigment in light. The Runyon group 2 are also slow growers. They are scotochromogens, so they produce yellow pigment if you place them in the dark. As for group 3, they are also slow growers. They are non-chromogens. They do not produce any pigment. And so one of the organisms that falls under this group, or rather a triad of organisms that fall under the Runyon group 3 are the Mycobacterium avium complex, which we'll talk about on the next slide. And then the last Runyon group 4, these are rapid growers and they usually grow within 3 days or a little bit more. And the last group, or rather class under this rudimentary classification, they are the ungrouped organisms, and these include all the other types of mycobacteria that cannot be grouped into the first two classes. And so this includes Mycobacterium leprae and lepromatosis. These cause leprosy, as you'll see later on in the lecture, and these do not grow in culture. The organisms that we're discussing in this lecture, the mycobacteria, most of them are non-pathogenic. They are found in environmental samples in soil and in water. However, there are some organisms under this genus of Mycobacterium that can cause human disease, such as Mycobacterium tuberculosis, which causes tuberculosis. However, this disease can also be caused by other agents like Mycobacterium africanum, which is mostly seen in Africa, or Mycobacterium bovis, which is found in cows. As we said earlier, the lecture will also deal with Mycobacterium leprae and lepromatosis, which are agents of leprosy, which is also called Hansen's disease. And the last type of organisms that can cause human disease, this is a complex called the Mycobacterium avium complex. And these are 3 organisms that actually cause infection together as a triad, and this would be Mycobacterium intracellulare, Mycobacterium avium, and Mycobacterium chimera. So these organisms, they infect at the same time, and the disease is referred to as Mycobacterium avium intracellulare infection or Mycobacterium avium complex infection. Here what happens is a chronic pulmonary disease that could disseminate in immunodeficient subjects. So it's mostly seen in the immunocompromised, especially people who have AIDS. It is the most common mycobacterial disease in the United States, which is unlike what you see in most of the world, where the most common disease you see worldwide under this genus would be the Mycobacterium tuberculosis. Starting with Mycobacterium tuberculosis. Pathogenesis. So the way we acquire this organism is by inhalation from respiratory and oral droplets. We inhale it. In about 50% of the population, you have no infection, nothing happens. And then in the rest, what happens is the bacteria will reach the alveoli, they go down in the lungs, they infect the macrophages there, and they replicate within these cells. So what happens next is a formation of a lesion that we refer to as granulomatous lesion or the caseous necrosis lesion. What's happening at this point is you are actually coughing the bacteria in the sputum. Now the lesion itself, in the majority of the population, it will calcify. So the lesion calcifies, the bacteria ceases to grow. That's in about 90 to 95% of the population. If this happens, then you should be fine later on in life, except for about 5 to 10% of the population who may have some form of immunosuppression. Their immune system activity is depressed, and so the lesion reactivates, and again the bacteria will multiply. You'll form more of the bacteria that will be shed in the sputum. Now this happens in about 5 to 10% of the majority of the population in which calcification happened. So what about the minor proportion of the population who did not get calcification? In that case, what happens is the caseous necrosis lesion will liquefy, and again you start shedding or coughing the bacteria in the sputum. And what happens in these people, if this is not appropriately dealt with, is that the organism will spread to the blood, to the organs, eventually resulting in death. Mycobacterium tuberculosis is only found in humans. As for Mycobacterium bovis, it is found in cows, and so people may rarely acquire it from cows or from milk. However, this risk has kind of decreased with pasteurization, with the evolution of hygienic methods of dealing with milk and with cows. Now, what about the disease itself? Once you acquire the disease through droplets, the first phase of the disease is referred to as primary tuberculosis, which lasts somewhere between 3 and 6 weeks. For the first 3 weeks, the skin test, which we'll talk about a little bit later on, is negative, and then after 3 weeks, it becomes positive. If you take an X-ray at this point, it is typically negative. In 5 to 10% of the population, we have the progressive primary infection, or the rather progressive active infection. In this case, the disease is active, as we saw on the earlier slide. And then in this case, the skin test is positive, the X-ray is positive, and we'll take a look at what the X-ray looks like later on in the lecture. And sputum is positive, so the person is coughing the organism up and, of course, is contagious. In the rest of the population, 90% of the population, you have latent dormant tuberculosis, so the skin test is positive, the X-ray might be positive or negative, but you're not actually producing the organism or coughing it up in the sputum. Of this, we have latent dormant tuberculosis. The majority, 90% of them, will have no further progression, but their skin test will always be positive. As for their X-ray, it might be positive or negative. In a minor proportion of them, the 5 to 10% we talked about earlier, in which the organism or the lesion rather could liquefy and reactivate due to some form of suppression in the immune system, what happens is you have secondary or reactivation tuberculosis. The skin test is positive and the X-ray is positive, and the person is coughing up the organism in the sputum and is contagious. In the first 3 weeks after infection, we have no symptoms, or alternatively, you might have some mild flu-like symptoms which are very generalized. Later on, what happens is you mount an immune response, which should be a Th1 response to contain this type of infection. And so what happens is the macrophages become activated and the granuloma is formed. This is what the granuloma looks like under the microscope. And compare that to this cartoon, which kind of shows you the constituents, including the presence of these lymphocytes as well as macrophages. Some of them are infected, and so we have replication of the organism there, and we have some necrotic tissue as well within this granuloma. Again, to reiterate, you need the Th1 response in order to contain the infection. So what happens is the skin test becomes positive at this stage. If you have a defect in cell-mediated immunity, what could happen is a primary progressive disease. If you are immunocompetent, replication will stop within the 3 to 6 weeks of the primary stage. And so what happens is that you contain the infection within this lesion. However, if you have an immune defect, like we said earlier, you might have progression and liquefaction of the lesion itself. If you harbor the organism, but there is no replication, it is contained within the calcified lesion. This is a clinically latent carrier state. The person is non-contagious, and this is referred to as tuberculous infection. Tuberculosis is a clinically active disease state, and here we have replication of the organism, it is contagious, and the person is shedding the organism in the sputum, so the culture is positive. Now, the organism has a small infectious dose, likely less than 10 organisms. Now, to give you a rough idea of how much a person can shed of this organism, one droplet usually is estimated to contain less than 10 organisms. And one sneeze can result in about 40,000 droplets. the organism does not produce toxins or enzymes, and so the manifestations are due to the immune-mediated responses of the host. The symptoms include non-specific symptoms that are not really particular to tuberculosis, such as fever, weakness, fatigue, chills, but there are others that are more related to tuberculosis, like a prolonged cough or a cough that lasts 3 weeks or more, blood in the sputum, loss of appetite resulting in weight loss, painful breathing, coughing resulting in chest pain, wheezing as well. Tuberculosis may affect other organs besides the lungs. This is referred to as extrapulmonary tuberculosis, and that includes multiple examples such as infection of the cervical lymph nodes, so you get cervical lymphadenitis. This is referred to as scrofula. It might affect the urinary tract and reproductive system, and this is referred to as genitourinary tuberculosis. You might infect the central nervous system, and as you probably know, this is, of course, meningitis. Tuberculosis may spread from the lungs in less than 2% of reported pulmonary TB cases, and this is referred to in this case as miliary tuberculosis. Now take a moment to think about the following question. I will read the question and then we'll give you some time to think about it before proceeding. So what type of immune reaction is required to curb the evolution of primary TB into primary progressive tuberculosis? A, one that is reliant on interleukin-4. B, one that does not depend on macrophages. C, one that involves interferon gamma. And D, one that does not rely on T cells. All right, I'll give you a little bit more time. Think about the type of immune system responses we were talking about so far that are required to contain the lesion and to contain TB in the lung. All right, your time is up. And so if you've answered C, that is the correct answer. In this case, what we need is Th1 mediated response to contain the infection, and that typically involves interferon gamma. A little bit about the epidemiology of tuberculosis. According to the 2017 numbers from the World Health Organization, the incidence of tuberculosis has been decreasing on a yearly rate of about 2%, and this is very likely due to improved hygienic measures as well as appropriate treatment administration. Now, the global burden of tuberculosis is in Africa. This is a hub for the disease, as well as some other areas of the world. In Lebanon, the current estimated incidence is about 12 per 100,000. The following are risk factors for progression to TB. So that is progression from the latent state to actually having an active TB disease. So persons are positive for the human immunodeficiency virus, that is HIV. This is the strongest risk factor. In this case, you have a 7 to 10% risk of progression. Somebody who was recently infected with the organism, particularly infants and very young children, they might progress to tuberculosis. Persons who have underlying medical conditions that weaken the immune system, as you've probably surmised from this lecture, the immune system and its intactness, particularly cell-mediated immune system response, is highly required for containing the infection. Persons who inject illicit drugs and persons who have a previous history of having TB but not properly treating it, all of these are risk factors for progression to active tuberculosis disease. As for diagnosis, it will rely on the clinical diagnosis, so the history and the physical exam, the Mantoux tuberculin skin test, or the PPD, which we'll talk about in a bit, imaging, so chest radiograph, and lab diagnosis, including, of course, culture and possibly serology as well. You can see here, just as an example of the X-ray and what it looks like, this is what cavitation in tuberculosis looks like, compared to what spreading of the disease looks like in miliary TB. You can see spreading. And so, like I said earlier, miliary TB happens in less than 2% of people who have tuberculosis. As for the Mantoux tuberculin skin test, or TST, it consists of PPD, which is the purified protein derivative, and you might hear people refer to this test as simply the PPD or the PPD skin test. In this case, the 5 tuberculin units in 0.1 milliliters are recommended to be administered intradermally, and that's recommendations by the CDC. And the reason why we bring this up is because it's important to be consistent in how and what you administer to be able to properly make conclusions based on what you see later on after the injection. So you give the intradermal injection and then you wait 48 to 72 hours, no less than this, no more than that. And what you should see is wheal and erythema region and the induration. Some people might incorrectly measure the size of the wheal itself starting from the erythema borders, but that's not appropriate. The induration itself should be measured, and if it is more than 5 millimeters or 5 millimeters or more, this is deduced to be positive. Now, false positives may occur due to previous exposure to mycobacteria, possibly due to allergic reactions to tuberculin, to the PPD itself. In addition to that, if you have been previously administered the vaccine for tuberculosis, you might be positive for the TST. And we will talk a little bit more about this later on. As for lab diagnosis, for culture, you need 3 sputum samples. These are obtained for acid-fast staining, followed by culture. If somebody is unable to cough, you should induce sputum and then culture can be performed. The cultures should be held for at least 6 weeks. These organisms do not grow very fast. You would not expect them to appear on a culture plate the next day like with some other organisms. On the average, growth appears within 2 to 3 weeks. You should also do the drug susceptibility test. Drug resistance with Mycobacterium tuberculosis is a concern, and so this should, of course, be taken into account. So drug susceptibility testing should be conducted. Now, since culture takes a long period of time, of course, people have looked at nucleic acid amplification tests. These are molecular methods. NAA tests help you avoid prolonged culture waiting time. And so there are 2 assays to refer to. The first one is amplification of an insertion sequence that is specific for the Mycobacterium tuberculosis complex. So this is not just for Mycobacterium tuberculosis itself, but for the complex, for the entire complex. That is including Mycobacterium africanum and Mycobacterium bovis. The insertion sequence is IS6110, and so you amplify this. However, you cannot tell whether this was actually Mycobacterium tuberculosis or some other organism within the complex. If you want to be more specific, you can do PCR amplification of the 16S ribosomal RNA gene, and then you follow that by probing for Mycobacterium tuberculosis. You use labeled probes or probes for Mycobacterium tuberculosis, a specific sequence within this organism if you want to be more specific with your molecular method detection test. As for treatment, it consists of 2 phases. The first phase is 2 months of 4 drugs, which are isoniazid, rifampin, which is also referred to as rifampicin, pyrazinamide, and either ethambutol or streptomycin. The second phase follows the 2 months of 4 drugs, and this is 4 months of 2 drugs, which are isoniazid and rifampin. You first start treatment upon diagnosis, and then it is adjusted based on the drug susceptibility test. If the organism is drug resistant, it might be resistant to one of the administered drugs, then you adjust accordingly. And of course, multi-drug resistance in tuberculosis is a particular concern, as I alluded to earlier. There is a vaccine. It is the Bacillus calmette-guerin, or BCG, and actually it consists of an attenuated Mycobacterium bovis strain. However, this vaccine has variable efficiency, and because of this, it is only recommended in specific people or populations such as children or healthcare workers who are heavily exposed to the organism. Now, the vaccine might later in life induce a positive skin test because you've been administered a Mycobacterium organism. The skin test might become positive despite not having infection or having been infected with the organism. And so from a rather public health perspective, it is more relevant to leave the vaccine to people who may be exposed to the organism or at risk, rather than complicate matters by having people who are positive with the skin test despite not having the infection or having had the infection. There are alternate vaccines in development, as you may expect. Now, for the next section, we will discuss the disease caused by Mycobacterium leprae or Mycobacterium lepromatosis. Both of these organisms cause similar disease. The disease caused by these organisms is leprosy, also referred to as Hansen's disease. This is a disease that affects the skin and peripheral nerves. It is a chronic disease that might also affect the eyes and the nasal mucosa. The organism is transmitted via droplets, via nasal and oral droplets. However, in the past, it used to be believed that being exposed to the organism and acquiring the disease is easy. However, this is not true. Once you acquire the organism, because the organism is a slow grower, the incubation period is long, and it ranges somewhere between 5 and 20 years and sometimes longer. We will discuss the clinical disease at length. However, what you should know at this point is that it ranges between two extremes, the tuberculoid leprosy, which might progress to affect the limbs and the eyes, in addition to the skin and nerves, possibly resulting in permanent damage if not handled properly, resulting in the other extreme, which is lepromatous leprosy. And so the tuberculoid leprosy, which is a more restricted form, is one end of the spectrum, versus lepromatous leprosy on the other end of the spectrum, and then somebody might fall somewhere along the lines of the spectrum, so somewhere in between. First, let's examine tuberculoid leprosy, which is the less severe end of the spectrum. Here what you see is a large, solitary, macular, that is flat, skin lesion. You might see a few lesions accompanied by loss of sensation, and there is no itchiness due to damage of the peripheral nerves, resulting in complete sensory loss. So there is no itchiness and there is no sensation there. These lesions usually appear in cooler body areas, so exposed areas, mostly the skin of the nose and the outer ears. The testes are frequently damaged as well. Now, if you have appropriate immune cell responses, specifically Th1 responses, just like with Mycobacterium tuberculosis, you might be able to contain the disease and the lesion may resolve on its own. The lesion, or this disease in this case, tuberculoid leprosy, is referred to as paucibacillary because it relatively has few organisms, and so there is low infectivity. Now, the more severe end of the spectrum is lepromatous leprosy, and this could happen if treatment is not properly given, or if the immune system doesn't respond properly with Th1 cell-mediated responses. The disease might progress to lepromatous leprosy, and what you would see is numerous macula, plaques, papules, nodules, disfiguration of the skin, and one example is the leonine face you're seeing in the picture here. This is a subject with multiple nodules on the face due to leprosy. Now, this is a case of high infectivity. You have a lot of the organism, so relatively a lot of the organism compared to tuberculoid leprosy, and so it is referred to as multibacillary. If the person is not properly treated, the subject would die within a couple of decades. As for the epidemiology of leprosy, the incidence has decreased in recent years, mostly due to appropriate treatment, which is available for free, as you'll see in a little bit. Now, the global burden of the disease is in Southeast Asia. They have the highest incidence of new cases, and this is mostly due to India. Most cases are seen in India. About 60% of new cases are detected in India. As for treatment, both extremes of the disease are curable, and what you would use is multi-drug therapy. Multiple drugs are given, a combination of things is given. For the tuberculous form, use dapsone and rifampicin, which is also referred to as rifampin, and that is used for 6 months. Regarding the lepromatous form, you give a combination of dapsone, rifampicin, and clofazimine, and that's given for 12 months. Now, this treatment, this combination of drugs, it is provided for free because of an agreement between Novartis, the drug company, and WHO. So far, there is no resistance that is reported, and the relapse rate is low. The vaccine, you've seen this vaccine in the tuberculosis section. It is the BCG vaccine, and this vaccine has a very high variability in its efficiency, and so, of course, as you would expect, there are better ones that are being developed. To conclude this lecture, I will give you a moment to think about the following question. In multibacillary leprosy, the nerve damage is managed by A. Sufficiently treating the infection with multidrug therapy, B. Administration of blood thinning agents to enhance blood circulation, C. Administration of steroids to curb the nerve damage caused by T cells, or D. Administration of antihistamines since the damage is caused by mast cells. I'll give you a moment to think about this question, but take into account what we've discussed today and how the disease is caused, what really causes the manifestations, whether it was for leprosy or for tuberculosis. All right, if you've answered C, then you've answered correctly. That's because with this disease, the nerve damage is caused by T cells, caused by cell-mediated responses, similar to what we saw with tuberculosis. And so if you administer steroids, you might be able to curb this damage. Thank you for listening, and this concludes our lecture.